in this to run, this session. Thank you, Ambassador.
Thank you very much, Dr. Heidi Getterham, the CEO at the Global Center for Health Diplomacy and Inclusion. I want to join him in welcoming all of you here in collaboration with the ACP group of ambassadors in Geneva at the UN side and CeHDI. We started last year this high-level dialogue to address issues on human rights, issues on health equity. Today's dialogue is towards a cervical cancer-free future. I am delighted that we are joined by ambassadors not only from the ACP, but today we are honored, we are privileged to be joined by the ambassador of Germany. Um, we are also joined by representatives from Africa, from the Pacific, from the Caribbean. We are honored to have in our midst, in person, the OECS ambassador from Antigua and Barbuda, Ambassador Colin Murdoch. We also are joined by the ambassador from Cabo Verde, Ambassador Delgado. In the room also, um, we are joined by the representative from the Suriname embassy. Um, and so we today will address a very important issue of cervical cancer. Although cervical cancer is both preventable and curable when detected early, it remains the fourth most common cancer and cause of cancer death among women worldwide. For some of our countries, like Guyana, for example, it is the number two cause of cancer deaths among women. For some countries, it's the number one cause of cancer death among women. Each year, about 600,000 women are diagnosed, and nearly 340,000 die from the disease. 6.5% of new cancer cases and 7.7% of cancer deaths among women globally. Cervical cancer has become a mirror of global health inequity. Despite the availability of highly effective tools like HPV vaccines, screening technologies, and proven treatments, approximately 94% of deaths occur in low and middle income countries. While some nations are approaching elimination thresholds, millions of women elsewhere continue to face preventable illness and death. While with existing tools, scientific advancement, and global cooperation, the world could achieve first elimination, the first elimination of a cancer, just as international collaboration led to the eradication of smallpox. The global community can work together to end cervical cancer by 2050. Recognizing this opportunity, WHO member states in 2020 adopted the Global Strategy for Cervical Cancer Elimination, committing to reduce incidence to below 4 cases per 100,000 women. Achieving this goal requires meeting the 90, 70, 90 targets by 2030. That is 90% of girls fully vaccinated with the HPV vaccine by age 15, 70% of women screened with a high performance test by ages 35 and 45, and 90% of women with precancer treated, and 90% of those with invasive cancer properly managed. The question is no longer whether cervical cancer can be eliminated, but when, and whether the world will mobilize the political will and resources needed to ensure that no woman dies from a preventable disease. Today, we have an opportunity to elevate cervical cancer elimination on the multilateral agenda as a matter of equity, gender justice, and the right to health. Our goal is to mobilize ambassadors, permanent representatives, and public health leaders as champions for HPV vaccination, screening, and treatment at national, regional, and global levels. Most developed countries, and we will hear from Germany today, are now positioned to eliminate cervical cancer by 2050. While some developing countries might be able to follow the same trajectory, we will hear from one of those, Barbados, most developing countries are on a trajectory of eliminating cervical cancer as far as 2120. We are hopeful that multilateral collaboration can lead to a global elimination by 2080. And therefore, today's high-level dialogue is a call to change the trajectory for elimination from 2120 to earlier, closer to the 2150, when many European countries and North America would have achieved that elimination. And if you're wondering why we are choosing 2180, it's because 2080 will be the 100th anniversary of the eradication of smallpox, the only disease to this time that we have eliminated. It will be unfortunate that when we celebrate the 100th anniversary, that we can't say we have eliminated a second disease. So today we will hear from other on this trend of it to elimination and the path to make it earlier than 2120 for global elimination. And so I also need to acknowledge that many persons are joining us online, and one of those persons is my colleague, the ambassador from Malawi. So let's get this ball rolling. I want to invite Dr. Natalie Brute to provide the global perspective on where we stand, what is working, and where the gaps remain. Natalie is a medical doctor with a PhD in infectious diseases, epidemiology, and public health. From September 2001 to July 2022, she worked at the World Health Organization in Geneva within the Sexual and Reproductive Health and Research Department. Since retiring from the CeHDI. She's not that old. She's been working as adjunct professor at the University of Sydney to support the implementation of cervical cancer prevention programs, and with UNIFOR in Brazil to organize a global health course for postgraduate students. She's also chairing the European Cervical Cancer Working Group to develop the European guidelines for screening and treatment of pre-cervical cancer lesions led by the IARC. So she will be talking to us today about the targets, progress, and inequalities in cervical cancer, the global perspective. So, Dr. Boutte.
Thank you, Mr. Chair. Thanks very much for your introduction. Can you hear me correctly?
Yes, yeah? We can.
Thank you. So I'd like to have the first slide. And first, good afternoon to all ambassadors, permanent representatives, senior diplomats, and global health experts and colleagues. I'm very pleased and honored to be with you today and to share with you some thoughts about how inequity can prevent to eliminate cervical cancer and how we can address it. So as you said, Mr. Chair, I've had the privilege at WHO to lead the development of the global strategy toward the elimination of cervical cancer that have been adopted by all member states in 2020. So now I'm a good advocate and I really spend my work on the implementation part of it. Next. So as you mentioned, Mr. Chair, cervical cancer is one of the few cancers that can be prevented, detected early and treated. But it continues, as you mentioned, to disproportionately kill women in low and middle income countries. And we need to address this inequity. And in order to address it, we need to understand why we have such an inequity and what are the special needs of girls and women that drive this situation in low and middle countries and also in high income countries. And based on that, we need to allocate resources and technology accordingly. So that to say that inequity is not a biological, it's a systemic issue that we need to understand and to address. Next. So as you mentioned, the WHO in 2020 proposed the global strategy toward the elimination of cervical cancer. And we proposed the threshold for the elimination of the public health problem to less than 4 cervical cancer cases per 100,000 women a year. And to give you an idea, most of the countries have a cervical cancer incidence between 4 and 10. Many countries in Africa, like in Eswatini, like Malawi, and countries also that are affected with HIV, have a cervical cancer incidence close to 60, 70, 80. So it's really a huge problem that we need to address. So in order to reach the threshold of 4 cases per 100,000 women a year, by the end of this century, we need to reach the 2030 target, which are 90% HPV vaccination coverage, as you mentioned, 70% of women to be screened with a high-performance test, such as HPV test, twice in a lifetime, and 90% of women detected with a cervical disease should be treated. Next. But still, we have a huge disparity between countries over the world. So this world map represents on top cervical cancer incidence per countries, and in red, cervical cancer mortality. And you can see the huge disparity between low and middle income countries and high income countries. And this is not linked necessarily to a higher or different epidemiology of HPV in countries. It just translates also the problem in accessing services, treatment services, and prevention services. But what this map doesn't show, it's also that within a country, even with a low cervical cancer incidence, we must never forget that we still have a hard-to-reach population and their needs need to be addressed too. So this is the global map but within country, we need to understand where is the disparity and where we can find inequity. Next slide. So these drivers of inequity, what are they for cervical cancer elimination in particular? So vaccination gaps is one. And because of the cost, because of misinformation, because also of delivery challenges, this is the first time that a vaccine has to be delivered to an adolescent population. So the system needs to be in place. Screening access, HPV testing are also expensive. And there is limited laboratory infrastructures in many countries and workforce shortages. Treatment capacity, we shouldn't have offered screening without having treatment. So treatment of precancer lesions need to be offered to women as well as treatment of cancer like radiotherapy. And we know the gap that we have in access to radiotherapy. And finally, which should be the first, in fact, it's the other social determinants. Poverty, gender norms, education, all these can be barriers to access services even when these services are available. So the elimination requires addressing all four pillars simultaneously. Next one, please. And with regard, I'd like to show you some data on HPV vaccination coverage and on screening coverage. With regard to HPV vaccination coverage, this is the graph that represents the coverage by WHO region. In red, the thick red line is the 90% coverage that we should achieve by 2030. You can see that apart from the region of America that almost reached 80%, the other region, like European region, African region, Southeast Asia, Western Pacific, they are below 40% coverage. So the work that we have to do to reach the 90% is enormous, and that really needs to be addressed. Next one. So, next slide, thank you. So we know what works to scale up vaccination, and that's the important message that I want you really to remember. School-based delivery are effective. We know in countries that use school-based delivery, there were quite of a success of HPV vaccination coverage, acceptability. Regional pool procurement are essential because they will help to reduce the price of the HPV vaccines. And this is an ongoing dialogue with manufacturers that need to be implemented. But regions need to gather, countries from the same region need to gather to get to this dialogue. Gender-neutral vaccination can improve the coverage and also lift some barriers that we can see with regard to the HPV vaccination of girls only. And strong community engagement. We need to inform the community, they need to understand. There is important also communication that need to be in place. Next slide. However, I think that even with HPV vaccine available, we need to ensure that these vaccines cover the needs of girls in the countries. So here is a very important work that the International Agency for Research on Cancer, IARC, together with the Global Center for Health Diplomacy and Inclusion, CeHDI, where we are now, are put together. It's about HPV 35 genotype. This is a genotype which is very common in African countries and which is responsible for around even more than 4% of cervical cancer cases in Africa. Yet, this genotype is not included in the current HPV vaccine. And we are gathering at the moment all the information available, the evidence, and starting to have dialogue with the manufacturer and with country to ensure that manufacturers include this genotype in the next generation of vaccine, to ensure that women that get this vaccine are really covered and will be protected against the genotype that are prevalent in their countries. And this is particularly true for the African countries. Next slide. With regard to the coverage, this represents the ever in the lifetime cervical cancer screening coverage. And you can see again here in a huge disparity between high-income countries and low and middle income countries. The blue one are the ones that have reached 70% screening coverage. And the red, pink, and orange one are the ones that has not reached it yet, and it will take time to reach this coverage, the 70% coverage. But even in the blue countries, most of these countries are still using cytology. So it's not the test that we recommend to eliminate cervical cancer. So what I mean by that, that even in countries that we think they reach the 70% coverage, there is a lot of work to be done to switch for the existing technology, which is basically in high-income countries cytology, and in low-income countries VIA, and all the countries need to switch toward HPV test. Next one. So with regard to screening, we know what works. We need to first increase access to HPV testing, and we need also to ensure that innovation is available, and that principally innovation that can close rural gaps. And one of them is self-sampling, so self-collection, and also urine samples. So we need also to ensure that countries have access to this technology. We also need to ensure that screening is linked to treatment. We've seen that, but it's very important. Countries implement pre-cancer treatment as a basic tool to reach the elimination target. Mobile screening clinics can be an option to increase coverage. Task shifting to community health workers, this expands coverage, and that will expand HPV testing, principally with self-sampling or urine testing. And finally, digital registry. We need to follow up and track women that have been screened to ensure that these women with a positive test have been treated. Next one. So we have a generation to end cervical cancer. And we have, as you mentioned, Mr. Chair, we have the tools. The science exists, the roadmap exists, but the inequity persists. And the political will determines the outcome by what? Adopting national elimination target, securing sustainable financing in countries and in cooperation, strengthening regional collaboration. We've seen why to decrease the price of the tools, invest in treatment infrastructure, and the most important, that should be the first, addressing gender inequities directly. And each countries of the world need to understand what are these drivers of inequity in their own countries, because it's different for each countries. So having that will really stimulate and will permit to achieve the elimination target. I'd like to finish with the last slide, which is a quotation from the former director of the UN Special Program on Human Reproduction, HRP, in WHO, Dr. Mahmoud Fatrallah. And it was a big and a very important advocate for women's health. And they always said that women are not dying because of diseases we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. So this is time now to demonstrate that we are at this point, that women's lives are worth saving. Thank you very much.
Thank you. Thank you very much, Dr. Brute. From the global perspective, we will now come to the experience of one of the countries, one of the developing countries, and this is from the Caribbean. Before I go to Dr. Kimberly Phillips, I want to acknowledge all those online who are joining us today, but particularly my colleagues from the Ministry of Health in Guyana, and the Presidential Commission on the Prevention and Control of the NCDs in Guyana, which I'm still the chair. They are using this as part of their activity in the fight against NCDs. And I want to say thank you to all of them, to the directors and senior staff of the Ministry of Health in Guyana that have joined us. We're very grateful. I should say to all of us here present and those online that the Minister of Health, the Honorable Dr. Frank Anthony, also sends his regards, and under his leadership, Guyana is one of the developing countries that is using the Gardasil 9 vaccine, which is providing broad coverage against HPVs. And from the presentation we just had, the part of our objective as ambassadors and public health professionals here in Geneva is to advocate and urge that the manufacturers, the scientists work so that the next iteration of an HPV vaccine also covers HPV 35. Because if we are going to have elimination, um, there are some countries, particularly those countries in Africa, where HPV 35 also account for a significant number of the cervical cancer cases. And so that brings me to my Caribbean colleague, Dr. Kimberly Phillips, the Senior Medical Officer and Head of the Non-Communicable Diseases Program in the Ministry of Health and Wellness of Barbados. Dr. Phillips is a graduate of the University of the West Indies Mona campus in Jamaica. She has a master's in public health from Cave Hill, Barbados campus of the same university. She has worked across Jamaica, St. Lucia, and Barbados in emergency setting and surgical care before settling into primary health care. Currently heading the Non-Communicable Diseases Program for the Ministry of Health and Wellness on the island of Barbados. Dr. Phillips will speak on cervical cancer prevention and treatment in Barbados. Dr. Kimberly Phillips. Dr. Phillips, you're on. Okay, we seem to have a problem connecting to Dr. Phillips, but whilst we're trying to get her, we will move on to the next part of our program. We have with us also Dr. Ambassador Caroline Bwanali Musa, the permanent representative of Malawi to the UN in Geneva, and host of the Women's Ambassadors Geneva Network. We have also, as I had indicated earlier, Her Excellency Ambassador Angie Lindertz. Did I get that right? The permanent representative of Germany to the United Nations office in Geneva. And so we have them as panelists this afternoon, and I will ask them some very specific questions. And so I want to go to our colleague, Ambassador of Malawi first. Ambassador, are you ready?
Yes, I am, Your Excellency.
Good, thank you. So we are meeting at a time when multilateralism is under great strain and development assistance is tightening. Cervical cancer elimination, however, depends on collective action. If we are going to succeed, we need multilateralism to work. Ambassador, concretely, how do you think we could champion South-South cooperation to allow Malawi to reduce the time span for cervical cancer elimination instead of looking at 2120 for all of us? Can we look at 2150 to 2180 as the period for global elimination? Ambassador.
Thank you so much, moderator. Good afternoon, friends, those in the room and those of us online. Excellency Moderator, Ambassador Ramsamy, our convening partners, the host, Dr. Gethan, and your team, all speakers, those who've already spoken and those who will speak, Excellency colleagues, distinguished ladies and gentlemen. First of all, let me thank you, moderator, for the leadership on such important initiative like this one this afternoon. And also I want to thank the CEO for Global Center for Health, Diplomats and Inclusion, CeHDI, for providing the environment where we can actually discuss these important issues, and also for the technical support that you always give to all of us. Moderator, your question is very important and is timely, given what we're going through. Multilateral mechanisms and the development assistance are supposed to create sustainable structures that will enable countries to create independently mechanisms that can be implemented in terms of policies and initiatives, like in our case today, the cervical cancer elimination. So we need these mechanisms to empower the country mechanisms so that we are able to move forward. The strain under which multilateralism is facing today and current tightening trends on development assistance or any challenge should not weaken our resilience to do what is right. It should not in any way shake us to do what is right or to protect the gains that have been made this far. We should translate these challenges that multilateralism is facing into opportunities for countries to continue from where the assistance is diminishing and come up with innovative ways of filling in the gaps. The best way probably would be to move from without to within. So what comes to my mind immediately is regional and inter-regional coordination, as the previous speaker also alluded to. Focused and practical South-South cooperation, among other initiatives. For Malawi, the agency to deal with cervical cancer is clear. In 2023, there were about 4,701 new cervical cancer cases and 3,440 deaths, giving Malawi one of the highest burdens, as also the previous speaker alluded to. Without accelerated interventions, hundreds of thousands of Malawian women could die in the coming decades. Malawi adopted a cervical cancer strategic plan 2022-2026, which should be reviewed since we are already in 2026, aligned with the WHO guidance. Key pillars include HPV vaccination, increased screening, and strengthened treatment. However, no country facing this burden can succeed alone. Countries with similar health system constraints should learn from one another, share success stories, share solutions to ensure that the fight against this deadly disease is won. I believe that The Africa CDC roadmap to eliminate cervical cancer by 2030 is so important. It provides a continental platform to coordinate action, reduce fragmentation, and promote South-South learning in HPV vaccination, screening, treatment, community outreach, and integration with HIV and primary health care. New mechanisms such as the Technical Working Group and Centers of Excellence in the region could be used as hubs for peer learning, training, and sharing practical implementation experiences across Africa and beyond. For Malawi, championing South-South cooperation means sharing workable, affordable solutions and technology transfer among developing countries in the Global South. More particularly and relevant for rural access, HIV prevalence, and workforce shortages. In a nutshell, moderator, colleagues, the current geopolitical landscape where multilateralism is heavily tested and development assistance is shrinking or running dry should not be interpreted as a death sentence to those who are fighting these deadly diseases. Rather, countries in the Global South must move forward together and not in parallel. Stronger regional cooperation will reduce fragmentation, strengthen developing countries, and accelerate progress towards elimination of the cervical cancer. I thank you, moderator.
Thank you very much, Ambassador. We will go now to our colleague, Her Excellency Ambassador Lindertz from Germany. And I will specifically ask the Ambassador to give us an idea of Germany's cervical cancer elimination timeline and how North-South cooperation can lead to accelerated progress in cervical cancer elimination. Ambassador?
Thank you. Thank you very much for giving the floor and the opportunity to be with you together. Also, excellencies and colleagues and friends. The timeline issue is one that we always read in papers that we have an official timeline to 2050, and maybe we'll make it until 2040. But the reality is that there is no such national action plan. But this is a medical assumption and assessment out of the reality we are facing. And it's true, we have achieved significant progress in Germany, and I heard the numbers from Malawi. We have in Germany, at least since 1971, introduced a yearly pap smear for women over 20 years. 71, which is how many years ago? I'm not so good in counting, but it's quite a lot of time. And we think the reason why we have managed to put down the numbers so far is because we started quite early with the pap smear for women over 20 years. So that was in the year 1971. And this screening measure has helped us to significantly reduce the cervical cancer cases and the death. So we have, of course, also implemented other measures that have been also mentioned as possible measures. Internationally, cervical cancer is the fourth most common cancer among women. In Germany, it ranks only 14th among new cancer cases in women. And we have maybe 3 to 4 programs that we are following. As I said, we have the pap smears for women over 20. In 2020, also, we introduced additionally a new cervical cancer screening program, which is part of our universal health coverage system and includes services free of charge. So that means that every 5 years, women over 20 are invited to a cervical cancer screening. It's an optional. I mean, they're not followed by police if they're not showing up, but most of them have the wisdom to do this. And health insurance covers a yearly pap smear for women over 20 and a yearly pap smear in combination with an HPV test for women over 35. So it's as I mentioned, the early detection efforts that we are following, but we also try to do more in the prevention field of HPV. Vaccination rates in Germany are still rather low. You will be surprised. We only have at age 15, 55% of the girls and 36% of the boys vaccinated, but we are introducing several measures to change that. First, we aim to increase knowledge about HPV infections and the vaccinations. That means doing trainings for the medical personnel to provide information on HPV. Then through information materials for parents and adolescents to inform the families. Then by declaring 2020-80 as the National HPV Vaccination Year to raise additional awareness. And that was mentioned also in the previous speakers' slots. We try to tackle misinformation and to strengthen the trust in the vaccination. So our Federal Health Ministry has set up an expert network to strengthen the ability of the public to recognize misinformation and vaccination myths. That was not only done because of the pandemic. I mean, we went all through this, that was a big boost to those information activities, but it was also earlier, and now it's also the case, so we have to combat that. And third, we try to strengthen our vaccination reminder system. So adolescents take part in standardized early detection examination, which is a chance to remind them of the HPV vaccination. And in addition, we are discussing an additional examination at age 9 to 10. That is a bit earlier than previously, which could further increase vaccine uptake. And our electronic patient record, which we are introducing, will include a tool to document vaccinations, and it could be possible in the future to include push notifications reminding patients or their parents to take up the HPV vaccine. And fourth, and this is my last point on Germany, we are aiming to decrease barriers. That means the HPV vaccination is part of our universal health coverage system and free of charge until age 18. And we are conducting a study to understand social and behavioral determinants which influence vaccine uptake amongst the population. And the goal is, of course, to implement targeted measures, reduce and by that reduce inequalities in vaccination coverage. Because, I mean, you might have the assumption that in poorer areas of cities where the less educated, it will be a lower rate. And I think in these studies, the results are pointing into that direction. If I have the time, 2-3 minutes to explain what we do on the global scale, because we are also, of course, try to support the global fight against cervical cancer, and the most long-standing partner, and everybody knows here in this room, but also on the screens, is Gavi. Since 2012, Gavi has supported countries in introducing HPV vaccination programs, reaching more than 80 million girls. And we will, of course, continue to continue our decade-long support to Gavi with a pledge of 600 million euros for the 2026-2030 funding period. And this is something, I think it's the core of the global action. But of course, financing must go beyond vaccines, and we need integrated approaches that link immunization, screening, diagnostics, treatment, and health system strengthening. That is why we started to work closely with the International Planned Parenthood Federation, IPPF, for many years, and IPPF brings these elements I mentioned together in practice, reaching communities with vaccination, ensuring follow-up screening, early diagnosis and timely treatment while providing comprehensive education on the topic. We also support UNFPA to expand HPV vaccinations and to integrate screening and treatment into primary health care. And we have a facility, or we try to use this facility more. This is the Global Financing Facility. We support countries with targeted financing to scale up HPV vaccination, screening, and treatment programs. We also have a lot of bilateral programs, but I don't want to be too complicated. But it's just the message is we recognized and noticed that this is especially under the gender equality approach. It's a scandal that we have such a different situation in developed and developing countries. It's and also it's something that if we look at the universal health coverage goal, which is very dear to our heart since many years, not only in Germany but also in Europe, I think that the cervical cancer could be a test case for whether we are really successful in that endeavors to expand our best practices or knowledge globally. Thank you.
Thank you very much, Ambassador. It was no coincidence or no accident that we requested Ambassador to join us this afternoon because we are aware of the considerable work that Germany has been doing in terms of North-South collaboration and its work with IPPF and UNFPA. More importantly, the work with Gavi. And I think that if we are going to achieve the 2080 timeline for global elimination, and that many more developing countries will join the developed countries to achieve a 2050 elimination timeline. Gavi will play a very significant role. So I want to acknowledge the work that Gavi has been doing and the fact that many developing countries were able to initiate their HPV vaccination program through the support of Gavi. So this is a time to, I'm an older man now, but if I were to use the term that the younger people use, to big up Gavi. So I want to come back. Before I go, Ambassador Saranga, the ambassador from Mozambique is present with us today. He's also the coordinator of the African Group of Nations. So we are very privileged to have you here this afternoon. And as we continue this work, Ambassador, because Mozambique is also doing some very good work on this front, and we'd like him at some point in the future to be talking to us about the experience of Mozambique. But I'll come back to our colleague from Malawi. The ambassador just spoke about misinformation and vaccination myths. And I wanted to ask you whether in Malawi, or not whether, because misinformation and vaccination myth is becoming a global problem. As Minister of Health in Ghana, I remember that we still do have 100% coverage for many of the vaccines during childhood. But in recent times, we have had to combat, particularly since COVID-19, we have had to combat misinformation. We have had to combat vaccination myth. And I wonder if Malawi is experiencing similar challenges. So, Ambassador, please.
Thank you so much, Excellency. First of all, let me join you also to thank Gavi for their support to all of us. And really, they are a very valuable partner in the fights and also in the issues of to do with the vaccines. Coming to misinformation, Malawi is not immune to that. As we all know nowadays with the social media, but also the cultural elements, religious elements come to play when something is introduced. And in Malawi, especially if you're looking at the vaccination in line with teenagers, yes, or those who are not yet married and those who haven't had children, you know, there will be always rumors to say if you vaccinate them, perhaps they will be barren, they will not be able to give birth later. Such misinformation are always there. And also beyond that, there are some based on belief, they don't also believe in taking vaccines. They think that if you are a believer, the Lord should be able to protect you. So we have that also, and they go around discouraging women, especially young women, to get vaccinated. I remember we had an instance where an initiative was launched to sensitize young ladies, those in their teens and early 20s, but also those who want to actually fight the good work, went around spreading those rumors that perhaps if the girls were vaccinated or the young women were vaccinated, the future will not be as good and as promising for them when it comes to issues of fertility. But that said, government has been really doing well, and working hard to make sure that appropriate information reach the targeted audiences. So we have campaigns, and we even involve the chiefs in the villages in the remote areas to sensitize their masses, especially the parents, so that they can encourage, as families, to encourage their children, the young ladies, to go and get the vaccine. And where possible, even in the universities and in upper high secondary schools, such campaigns reach them to make sure that everyone is informed. And also we have TV and also radio programs that sensitizes masses on the importance of early screening, importance of seeking medical support, importance of getting vaccinated. So all in all, Ambassador, Malawi is doing all it can to address the issue of misinformation because we are not immune to that. Always you will find that people find even a simple thing like using mosquito nets, to take care of malaria, to protect people from malaria. There are stories that move around indicating that if you sleep in a mosquito net, you may lose your fertility, stuff like that. So misinformation is always there, but we are doing what we can as government and also as civil society. They go around and sensitize, especially girls. We realize that a healthy nation is very important. If we want to talk about development, we need to protect everyone. And the young ladies, the young women are more important than the future of the nation. So we're doing all we can to make sure that the right information reaches the targeted audiences so that they can get the support and the guidance that they need timely. Thank you.
Thank you very much, Ambassador. I'll come back to both panelists in a few minutes, but I want to go now to Her Excellency Ambassador Clara Delgado Jesus from Cabo Verde and ask about the experiences in Cabo Verde.
Thank you, Your Excellency. Thank you, dear moderator. I'm here today to speak about Cabo So maybe I will start by, maybe for those who may not know, the ambassador of the Congo, Clovis Guillaume, and I, we represent African constituency on the executive board of UNITIDE. So here as a member of UNITIDE to speak about the work that we are doing at UNITIDE. Excellencies, distinguished colleagues, ladies and gentlemen, it is an honor to address you today on behalf of UNITIDE at this important diplomatic dialogue on cervical cancer elimination. Maybe I can also explain. The board is, we are about 13 members of the board. We have Brazil, Chile, France, UK, Korea, Japan, African Union. So I represent African constituency, NGOs, communities affected by disease, Norway, Spain, and also the WHO. Your Excellency, let me begin with a stark reality. Cervical cancer claims the lives of nearly 350,000 women every year. Over 90% of these deaths occur in low and middle income countries, like ours. Women living with HIV face 6 times the risk, and yet this cancer is preventable, detectable, and curable. Since 2019, UNITIDE has positioned itself as a global leader in cervical cancer, secondary prevention, the screen and treat approach that saves lives today. While HPV vaccination remains essential for future generations, screening and treatment is the most urgent intervention for the millions of women who cannot benefit from the vaccine. Over the next 50 years, scaling up screening and treatment could avert up to 14.6 million deaths, 3 times more than vaccination alone. What has UNITIDE achieved concretely? So we have first, innovation and access. UNITIDE has introduced HPV testing, self-sampling methods, and thermal ablation treatment device across approximately 150 of all low and middle-income countries. We have driven down costs significantly, reducing HPV test price by 40% and thermal ablation device price by 45%, making these life-saving tools affordable where they are needed most. Second, country-led models that work. For example, in Rwanda, with UNITIDE's partnership since 2019, a national screen and treat program now operates in over half the country. Women in rural communities are being reached through HPV self-collection kits, a simple, dignified approach that brings services closer to home, breaking barriers of distance, stigma, and cost. Rwanda is on track to beat the global elimination targets by 3 years, proving that elimination is not just possible, but achievable, as I mentioned before. Third, a truly global vision. UNITIDE is now accelerating its response across the continents, working with partners, including Expertise France, WHO, and Pan American Health Organization in countries spanning Asia, Pacific, and Latin America, and the Caribbean. We are supporting champion countries: Rwanda, South Africa, Malawi. I see my dear sister, ambassador from Malawi, and the Philippines, while ensuring that a high-border nation from India and Nigeria to Myanmar and El Salvador are not left behind. South-South learning and community engagement are the heart of this approach. And fourth, frontier innovation. UNITIDE is advancing AI-powered screening tools and through point-of-care HPV diagnostics and could enable same-visit screen and treat, transforming what is possible in the most remote and underserved settings. These technologies, co-created with national governments and communities, are designed to be integrated into routine health services for long-term sustainability. Excellencies, cervical cancer elimination is not a distant aspiration. It is within reach if we act with political will, sustained commitment, and solidarity. UNITAID stands ready to continue this work alongside all of you. In this regard, UNITAID issued a call for proposals in January to strengthen efforts to eliminate cervical cancer. As a diplomat from Cabo Verde, a small island development state that understands the power of multilateral action, I am personally committed to this cause. No woman anywhere should die from a cancer we know how to prevent. I thank you so much.
Thank you very much. And that gives me also the opportunity to big up Unity. Um, as we are now focused on cervical cancer elimination, I remember the early 1990s when HIV and AIDS truly at the time were being thought of as an existential issue. It was ravaging globally all populations. And here we are in 2026, where the talk of ending AIDS is real. It is no longer a utopian idea that we could end AIDS. We are now on a similar trajectory when it comes to cervical cancer. It is not wild talk. It is possible. We can end cervical cancer and make it the first cancer that we have been able to end. And that's because of global collaboration. Not only did we establish the Global Fund, but we had organizations such as the Clinton Foundation, Unit Aid, PEPFAR, making real global collaboration, North-South, South-South collaboration. And so Unit Aid became an important part of that global cooperation, shows what we could do in addressing global public health. And so what I wanted to ask our colleagues, ambassadors from Malawi, Germany, Cabo Verde, is and our ambassadors from Mozambique and the OECS is, can we learn from the lessons of HIV? Other than vaccine, all of the technology and the strategies, education and awareness, there are still a majority of people in many of our countries who are not aware of the vaccines, who are not aware of the role of human papillomavirus. And so can we learn from HIV and therefore be able to accelerate the efforts? I will come to my colleagues from Mozambique and Antigua Barbuda, but I'll give them some time to think. So I'll go back now to our colleague the ambassador from Malawi.
Thank you so much, moderator, for that important question. Perhaps before I respond to that one, let me give you the good news that much as we are seeing that this is a big challenge, but there is, the silver line to it. There is good news. In 2025, in Malawi, we managed to vaccinate about 2.27 million girls, 2,270 million girls aged 9 to 18, and that's achieving 91% coverage. And this was achieved because we managed to have an outreach program targeting school-aged girls and out-of-school adolescents through community-based outreach. And also we went through markets, even in the markets, bus stations and residential areas. So we managed to do that. And that was done with the support or partnership by Gavi and also WHO and UNICEF. So I also wanted to agree with Ambassador Klal that it is not possible only, it is achievable, it can be done. And indeed, we can wake up to a new world, which is the cervical cancer free, if we really put our efforts together, if we work together, if we support each other, if we lend a helping hand, and really share even the strategies that we use in our countries that can be done. Now, going back to the issue that you mentioned, that can we learn some lessons from HIV? Yes, we can. We can learn the positive ones, and we can also learn those that we didn't do well and build on them so that we can do better this time. For instance, the cultural obstacles that were there during HIV, where people could not go and get medication or treatment because of cultural barriers or beliefs. That also, transfers into this topic we are dealing with today, the cervical cancer. However, I would say that the times are different. When HIV and AIDS came about in the early 90s, the world was not as open as it is today. So it's not as hard as it was then, with also the presence of social media, which was not very strong then. So the life now, it's much better. But the way I look at HIV AIDS lessons that we could learn, perhaps not more into lessons, but using the available structures to actually, help when it comes to sensitization, because we have already structures on the ground that we use to sensitize people on HIV. We could use those ones as well to sensitize people on the cervical cancer. And also when it comes to screening, right, the same structure that we have on the ground in our countries that are actually helping in the screening of HIV and AIDS could be used. And when people perhaps go to do screening of HIV, we could encourage them as well at the same spot and the same time to go and do the screening of the cervical cancer, especially the ladies, in this case, the younger generation, the young women. So I think we could benefit actually from the experience that we got from HIV and AIDS in terms of screening and treatment. And the person, it will be cheaper also, because the people are there, the facilities are there, the institution is there. So it could also, help financially to escalate the numbers in terms of screening and treatment. So for me, I think it is important that we streamline these efforts. We should not just handle them in isolation. We can put them together and make sure that people benefit when they go to the clinic to test for HIV. They can also test for cervical cancer. And if they are due for treatment, we can also find a way to combine this so that people can be going there to collect, for example, their drugs for HIV and AIDS, and also to get medication or whatever treatment that they can get in line with the cervical cancer. So that's what I would say, Ambassador. Thank you.
Thank you very much, Ambassador. I will want to ask Ambassador, or a colleague from Mozambique, Ambassador Sarango, to make some remarks on the fight against cervical cancer in Mozambique as one good example in Africa also.
Thank you, Ambassador Ramsamy, for the invitation to be here this afternoon. I also want to thank the Center for the Global Center for Health Diplomacy and Inclusion for being part of the organization of this event, as well as the panelists, both in the room and online, for providing very important information on the matter discussion. I want also to just share some few data on what is happening in Mozambique in combating this problem, which is a public health problem, not only for Mozambique, but for many countries globally. Yes, in Mozambique, this continues to represent a serious public health challenge. Unfortunately, the burden of this disease falls in a very disproportionate manner to low and medium income countries. That is the case of Mozambique as well. So the cervical cancer continues to be the most common type of cancer among Mozambican women over 25 years of age. Just to share you some figures, in 2022, for instance, the incidence and the mortality rates were estimated around 47.8 and 36.9 per 100,000 women, respectively. So the figures speak by themselves. They expose the seriousness of the matter in Mozambique. But we, as a country, we are aligned with the global strategy and vision, and we've been implementing a series of strategic interventions aimed at accelerating progress towards eliminating this kind of disease in the country. I just want to highlight some advancements that the country has been registering in this area. One, we have introduced in 2021 a vaccination program against HPV for girls aged 9. To have expanded in a very significant way the screening and treatment of precursors lesions in health facilities. And as we speak,
but still, you gotta keep a check on the pressure, right? Because surgery, yes, is a trigger. It's stressful and can elevate your blood pressure, but now you're recuperating. You want to see if it's still high, because if you never checked it before, right, and you only notice it around surgery time, maybe you had it before. And it could.
Thank you. Yes, I was sharing that at the moment, about 93% of our health facilities do perform screening, and 86% of them also do offer treatment for these kind of precursors. We have also introduced the some innovative technologies, including pilot scale HIV, DNA testing, and thermal ablation for the treatment of percussion lesions. And we have also developed and approved in 2022 and launched in 2025 the national roadmap for the elimination of cervical cancer by 2030, which has been the guiding instrument for any action that the country is carrying out in this respect. But of course, despite this progress, we remain vulnerable. We still have challenges that we ought to overcome. Among them, among those challenges are the limited literacy of the population regarding the disease prevention and the late seeking of health services by women. There will always be a tendency of women or among women to resort to these facilities, health facilities, only as the last resort. They will always resist, especially in rural areas. And we also have some limitations in terms of availability of essential supplies for screening and treatment. We also have, still have a heavy dependence on vaccines from abroad, which also limits our capacity to fully implement the strategy that the government has put in place. So we believe in that with resource mobilization of all actors, with the better coordination and commitment, we can meet the targets of broader, if not overall coverage, the country in terms of provision of services aimed at reducing the levels of cervical cancer in the country. So this will be, short, my comments, and once again, thank you for the opportunity.
Thank you very much.
Well, thank you so much, Ambassador Ramsamy. And I would also like to thank CeHDI and for inviting me to be present at this event, at which I've learned so much. And in fact, I'm very encouraged by what I've heard. I am not a medical person, unlike yourself, Ambassador Ramsamy, and I feel a bit of an interloper in this setting. But I would like to just give a bit of an overview and outline of how the OECS has approached this issue. Here in Geneva, first of all, I find myself often having to explain what OECS is. And OECS stands for Organization of Eastern Caribbean States. And it is an intergovernmental organization comprising 6 small states in the Eastern Caribbean: Antigua and Barbuda, Dominica, Grenada, and the 3 saints, St. Kitts and Nevis, St. Lucia, and St. Vincent and the Grenadines. Now, perhaps a unique feature of OECS also is that it also comprises, as associate members, the overseas territories of several European countries, so that we have Martinique and Guadeloupe and Saint Martin as French territories, because they fall betwixt and between the other OECS countries. We have Montserrat, Anguilla, and the British Virgin Islands as overseas territories of the United Kingdom. And we are currently in negotiation with Dutch Sint Maarten, and more recently with Curacao regarding membership in our organization as associate members. And OECS is basically, because we are so small, we find it very useful to do things together. So we are basically an integration movement. We have integrated our economies. We have a single market and economy moving towards complete free movement. We have many of the features that you see in the EU. Single currency, a single central bank, free movement of people, free circulation of goods, common institutions, in telecommunications, in civil aviation. We have a single Supreme Court. So all these are features that I think any person who lives in Europe will be very familiar with. And we have regional councils of ministers who manage the regional integration. And one of them is regional OECS ministers of health, responsible for health. And in my view, I have found that of all the councils of ministers, the ministers of health are the most active. And I think this activity and their collaboration was galvanized by COVID, when COVID presented an existential threat to OECS member states, and the ministers of health actually leapt into action. And they have maintained that high level of collaboration. They meet the most regularly of all the ministers, quite often by remotely. And on this question, there is regional cooperation, which is mandated by the OECS Treaty. But each individual member state is allowed to do their individualized program relating to HPV. How the OECS coordinates, and they provide certain support activities, for instance, in public relations and in education relating to HPV. And all this, again, I think, stood on the platform of COVID-19, when the public education program relating to COVID and the vaccine was very strong. So that, for instance, in Antigua and Barbuda has had an HPV vaccination program since 2018. And support is provided by the OECS through the PPS, which is the Pharmaceutical Procurement Service. OECS members procure their pharmaceuticals jointly. They have a program which has existed for many years in all pharmaceutical areas, where, because you get volume discounts, they join together and do one procurement of their pharmaceutical products, which are then distributed to the member states. And so they support the HPV program with this as well. The HPV cancer is in fact one of the most prevalent cancers in our region. And I think that is the reason why, but it differs of course within each territory. And that is the reason why this program has been started. My understanding of it is more limited to what is happening in Antigua and Barbuda, where I said the program has been going on since 2018, and it aligns very well with the regional program in the wider CARICOM and the international program. So basically, that is what I think I would like to say about the program as
Thank you, Ambassador. Um, so yes, as I bring this program to an end, want to remind everyone that CeHDI has been very generous in supporting us as we continue the high-level dialogue. The conveners of this particular high-level session include Guyana, Mission of Guyana here in Geneva, Canada, Barbados, um, and in this particular case, Germany. Said CeHDI is an important part in the ACP, and Malawi are the conveners. We will continue to work with each other. Clearly, as we have heard today, in terms of the first target in the WHO strategy, vaccination, we are off track globally. But I think after a slow start, we are beginning to accelerate. And I'm confident that many of us will be in a position to say we have achieved the first target. The second target and the third target are a little bit more difficult because access to testing is still very difficult in many countries, and access to treatment. But here too, with the efforts of the WHO, with the efforts of UNAID, with the efforts of many global partners and North-South, South-South collaboration, we're beginning to see greater access for access to testing, high-performance testing, and for treatment. And so whilst some of us may miss the 2030 deadline, I think the picture today is a little bit more optimistic than when it was, than we were last year. I'm hoping that programs like this and this high-level dialogue will contribute to reducing the gap that exists right now. To all of our colleagues here present, to all those who are online, I want to say thank you. I want to say thank you to my colleagues in Guyana, where after a slow start, we are now past 70% in vaccine coverage. There is free access to testing, both in the public and private sector of Guyana. The government of Guyana is paying for private access where people prefer that. And in terms of treatment, Guyana is providing a broad set of treatment options. Um, and so I think the picture today looks much better than it was yesterday. But there is vast room for improvement. I believe if we are able to achieve the WHO targets of 90, 70, 90, we would have positioned our world for elimination by 2050 for many countries, but certainly 2080 look possible for global elimination. And I hope that the 2120 estimate for many countries is not the timeline and the roadmap that we utilize. Um, so with that, let me thank everyone. We will continue this high-level dialogue, and very shortly, we would send out notification for the next dialogue here. And meanwhile, I want to encourage all ambassadors and permanent representatives in Geneva for us to work together. As I bring this session to end, I want to remind that the last dialogue was on universal access to menstrual products for all girls and all women. That should be a public good. I want to encourage ambassadors and public and permanent representatives here in Geneva for us to continue to strengthen the coalition so that no girl, no woman is lacking of menstrual products. Thank you all very, very much. See you next time.
Thank you, Ambassador.
Thank you.